Hello, everybody. We are going to go ahead and get started. I would like to welcome you all to our webinar today, Care During Crisis, How Telehealth Policies Can Expand Health Services for Students and Families During COVID-19. We're excited you all could join us today. We have a big group and really appreciate everybody taking the time to join, given everything folks have going on right now. My name is Alex Mays, and I'm the National Program Director at Healthy Schools Campaign, which is the organization that's co-hosting today's webinar with Trust for America's Health. And we're doing this as part of a joint effort we lead called the Healthy Students Promising Futures Learning Collaborative. I'll share a little bit more about the Learning Collaborative in a moment, but first just wanted to review a few logistics for today's webinar before we get started. Our webinar is going to run for about an hour, and the slides and recording will be available early next week. So we'll send out an email with a link to the slides and recording, and we'll also archive them on our website. We will save the last 15 or so minutes of the webinar for question and answer session with our wonderful panel. So as you think of questions throughout today's session, just go ahead and type them into the questions box on your control panel. Send them in and we'll collect them and make sure we ask them of our presenters at the end. Next slide, please. So today, as our webinar title describes, we're going to really be digging in around how states are making policy changes to expand telehealth services through Medicaid during COVID-19. We're also thrilled to be having a team from Ohio joining us that is really going to speak to what this work has looked like for school health services within Ohio and how Ohio has thought about leveraging some of these new flexibilities to support access for school health services via telehealth. Next slide. I just want to take a moment to thank our supporters of this work who make webinars like today's possible. They're listed up here. We greatly appreciate their support of the Healthy Students Promising Futures Learning Collaborative. Next slide. We have a fantastic lineup of speakers for today's session. We have May Kwong, who's the Executive Director of the Center for Connected Health Policy, Leslie Scott Charlton, who's Medicaid School Program Administrator with Ohio Department of Department of Medicaid, and then Bernadette Laughlin, who is with the Ohio Department of Education. We also have Mark Smith with the Ohio Department of Education, who won't be giving the formal presentation, but will be weighing in during the question and answer session. So we're thrilled to have them all with us today, sharing their expertise with the group. Next slide, please. So before I get started, I just wanted to very briefly say a little bit more about the Learning Collaborative, which is the effort that this webinar is being hosted through. The Learning Collaborative, again, is a joint effort of Healthy Schools Campaign and Trust for America's Health. Next slide, please. And it's been in place for almost 4 years now and brings together 15 states that are really focused around how to support expansion to Medicaid services in schools and promote safe and supportive school environments. Next slide. And so there's a map of the 15 state teams that are participating, and all the state teams have state Medicaid represented, state education, and then school districts as well, in addition to a range of other partners. So I just share this because the Learning Collaborative is a really fantastic opportunity to connect with folks around peer-to-peer learning for opportunities to support school health services, and telehealth has been a key focus of this work from the start. So if your state is in green, the state is already in the Learning Collaborative. We would love to connect you with great work that's happening in your state. And even if your state is not in green, we are always looking for new states to join. So if you're within a state agency, within a district, or a state level advocacy group, it's a fantastic opportunity if there are conversations that you're interested in really moving forward around how to expand Medicaid funded services and really create safe and supportive school environments. Next slide, please. So as I shared, school telehealth services have been a core focus of the Learning Collaborative from the get-go. And during these times of social distancing, we know that more and more health services, both physical and mental health services, are being delivered through telehealth. And so many schools we know had already moved in the direction of telehealth or were moving in the direction of telehealth, but the COVID pandemic has really rapidly accelerated the use of these services for students. And so we know all across the country, school-based health care providers are delivering services through telehealth to reach students and really to continue the delivery of these services during school closures. From a policy perspective, which is what we're really going to dig in today, we see unprecedented partnership opportunities across many areas. We have federal and state policymakers who are rapidly making policy adjustments to ensure that providers are allowed to use telehealth for appropriate services and that they can get paid. And states have a tremendous amount of flexibility to do this under the Medicaid program and are really working with districts and a range of healthcare providers to make sure services are being delivered via telehealth and also can be reimbursed. So many of the new policies under which we are operating today are temporary and in response to the COVID crisis. But at the same time, states really do have tremendous flexibility in their state programs, and we really find this as an opportunity to kind of take stock of what has happened over the last 6 weeks or so and think about, how we might want to support some of these changes moving forward. So today we're really going to dig in around how states are responding to COVID by taking action to move towards more services delivered through Medicaid telehealth, and then what that means for school-based healthcare services. We're going to hear a broad national perspective from May, who will speak to the recent changes in telehealth policy we've seen across the board. And then we'll turn to Ohio, who will really help us understand, how they have specifically looked to leverage some of these flexibilities to allow more school health providers to deliver these services. And just to share that Ohio is a fantastic example. We're also seeing this trend in many other states. Just as examples, Massachusetts, Michigan, Virginia, as well as many others, have begun to use these new telehealth flexibilities to really support the delivery of school health services during school closures. So next slide, please. Without further ado, I'm going to introduce our first speaker. So May Kwong is the Executive Director of the Center for Connected Health Policy. She leads the organization's work on public policy issues as they impact telehealth on the state and federal level. And she is also the Project Director for the National Telehealth Policy Resource Center. May is a nationally recognized expert on telehealth policy. And in her current role at Center for Connected Health Policy, she works with the organization's multitude of national and regional partners on telehealth issues, provides policy technical assistance to state and federal lawmakers, industry members, providers, consumers, and others. So we are thrilled to have May here today. Center for Connected Health Policy has been doing an incredible job of tracking state-level changes during the COVID crisis. So really appreciate May taking the time to join us today and share the work that they've been leading in response to COVID. So May, I will now hand it over to you. And I think we'll go to the next slide.
Thank you, Alex, and thank you everyone for having me here today. Next slide, please. So I'm an attorney, so I always have to start off with a disclaimer, and also I'm sure my funders would wish me to do this as well. So any information I provide today is only for informational purposes. It's not considered legal advice. And if I happen to mention a company or show some type of piece of equipment or mention a piece of equipment, know that neither I nor CCHP has any financial interest, relationship, or arrangement with such a company. Next slide, please. So CCHP actually was established in California in 2009 as a California telehealth policy organization underneath as a program of the Public Health Institute. We became the federally designated National Telehealth Policy Resource Center through a grant from HRSA back in 2012, and we've been serving in that capacity ever since. We also work with a variety of funders and partners on more specific projects related to telehealth or connected health, and those are just a couple of the different groups that we have worked with. Next slide, please. So some of the projects that we do a 50-state report on all the telehealth Medicaid policies, laws, and regulations. We do updates twice a year in the spring and the fall. We actually are in the midst of our spring update. We were in the midst of it when COVID-19 hit. So the information that we have available right now is good through October 2019, but we should have an update coming within the next couple of weeks, and the information will be good to the end of February 2020. We have not included the COVID information in because a lot of it, as Alex mentioned earlier, is temporary. We do have like a separate section on our website of breaking COVID-19 related telehealth policy changes. We also act as the administrator for the National Consortium of Telehealth Resource Centers, and I'll explain that in a moment. And a project that we do in California is that we're convener for something called the California Telehealth Policy Coalition, which is a coalition of over 70 statewide groups that are interested in telehealth policy in the state and how best to move forward with such policy. Next slide, please. So I mentioned the National Consortium of Telehealth Resource Centers, and what this is that there are 14 telehealth resource centers who all receive funding from the federal government through HRSA. And what we all do is we provide technical assistance to people who have questions around telehealth. There are 2 national centers, CCHP is the one on policy, and then there's one on technology, and then 12 regional resource centers that focus in on particular states. We all work very collaboratively together. So I like to say, if you reach out to one of us, you actually get all 14 of us. But if you are interested in like telehealth on your regional level, your state level, really start with your regional telehealth resource centers because they do cover those specific states. They have expertise in that state. But feel free to reach out to any of the 14. Like I said, we all work very collaboratively together. So if one of us can't answer whatever question you have, they go to the other 13, and typically somebody does have an answer or a resource that they provide, or they try to go and find the answer for you. Next slide, please. This is just a snapshot of our website. I talked about the 50 state report. So we keep that information available on our website. It's publicly accessible, and we put it in an interactive map. You can download the PDF. The report itself is like 450 pages. But if you're just interested in a particular state, you could just click on the map and it'll bring up the information as well. Next slide, please. So I know this topic here is to talk about the Medicaid programs, but I'm going to spend some time talking about Medicare, and there's a reason that I'm doing that. One is that a lot of the policy changes we've seen have on the federal level have been associated with Medicare. But what also happens is that the Medicare policy changes have an impact on the Medicaid policy changes, either directly with like some of the restrictions that they're loosening, or indirectly, and that at times Medicaid mirrors what happens in Medicare as far as where telehealth concerned. Even though, as Alex mentioned, the Medicaid programs actually have quite a bit of flexibility of what they can do with telehealth. But as I get through what's going on the federal level, what you're going to see is that some of the policies that they're adopting on the federal level are being mirrored on the state level, or they are taking things related to telehealth that they're doing on the federal level and also incorporating them in their Medicaid programs. And I'll explain that portion in a little bit. But right now on federal policy, sort of like the main pieces that have impacted telehealth policy the most during COVID-19 have been these sources. So you have 2 federal bills, CMS guidances that they've issued. They also issued an interim final rule at the end of March that also has some influence as well. And then one not directly related to Medicare, but DEA guidances that I think will have implications for the students that you're trying to serve with your programs. Next slide, please. So this is not all of the changes that have happened. There have been like a lot of changes. So I just picked out a couple of examples that I think probably would have like the most impact on what you're doing in the state level on Medicaid programs. So pre-COVID-19, Medicare actually had one of the most restrictive telehealth policies out there. A lot of states actually were much more forward-thinking or much broader in what they would allow for telehealth in their Medicaid program than what Medicare would. The reason for that is because Medicare is hampered by a lot of these restrictions are actually in federal law. So it would require literally an act of Congress in order for them to have more flexibility or be able to change things. And the restrictions were around sort of 4 areas, and the 4 areas were the location of where the patient is, when the telehealth service took place, who could provide the services, the types of services, and the modality that's used. Now, I'm just going to focus on a couple of those things that were limiting the factors that could, as I said, have an impact on the Medicaid program. And the first one is location of the patient. So obviously with your programs, when you're talking about school-based programs, we're talking about the school being like an eligible place for the patient to be located when a service takes place. In this situation now with COVID-19, where schools are closed down and you're trying to service children at home, that's also like another important factor. So for some Medicaid programs, schools may not have been an eligible site, and for a lot of Medicaid programs, homes were not an eligible originating site. So one of the things that they have done on the federal level, at least, is to remove that type of limitation of like where the patient's located. Because Medicare beforehand, they had it really restricted to essentially a healthcare facility, such as hospital, clinic, doctor's office, that type of thing. And a little bit of, they allowed a little bit in the home with just like specific services, but they've removed that type of restriction. And what you've seen mirrored then on the state is like something similar to that, and like realizing people are staying home and removing like that site restriction that they may have had in place with their Medicaid programs. Eligible providers. Medicare actually has a very limited list of providers that are allowed to provide telehealth services and get reimbursed by the Medicare program. One of the most glaring omissions from that list, although there are quite a few of them, is that they did not allow federally qualified health centers and rural health centers to be an eligible distance site provider. They could not be that telehealth provider providing services to the patient. So they did do this on a temporary basis, allowing FQHCs and RHCs to provide services and get reimbursed for them. Again, another sort of policy change where it may not have happened on the state level. States were varied in like if they would allow FQHCs and RHCs to be that distance site provider providing that services. We see here on the federal level that at least in this temporary situation, they're allowing that, hopefully mirrored more so on the states in their Medicaid programs, that they too will allow it, because I do know a lot of FQHCs at least do provide that service or act as that distant telehealth provider to school programs as well. Other things that have changed is around HIPAA and patient protection information, really relaxing some of those requirements. The way they've done it is that they said OCR, Office of Civil Rights, has said that they will exercise enforcement discretion and waive penalties for HIPAA violations. So allowing a little bit more leeway for providers to quickly ramp up and maybe not be as careful as they would have, in a non-crisis situation with the technology. They're saying we're giving you a little bit of relaxation there. And again, that's something that we're going to see mirrored on the state level as well, possibly relaxing some of those health protection information types of requirements and laws, because this just applies to HIPAA. A lot of states have their own laws and regulations regarding how to protect patient information as well. Copays and deductibles, again, allowing some flexibility on that. Not only is that a financial issue possibly with the patient, but there's also a possibility of stark or anti-kickback concerns about that if you don't charge a copay and when you're supposed to. It's sort of seen as an incentive of trying to get the patient to go with a telehealth provider, no-nos underneath some of these other laws and regulations like Stark and anti-kickback. So relaxing some of those and allowing that as well, not running afoul of other types of requirements. Next slide, please. A few other things that could impact a Medicaid program licensure. There was a little bit of confusion when this was first announced in sort of in March, where they said, the Fed said, oh, we're relaxing licensure. The problem is that that's actually controlled by the state. So people are a little bit confused on what would happen with how that would happen on the federal level. And what they were saying is that there are requirements within Medicare around licensure and having the provider licensed in the same state the patient who's being treated is located in. And they were saying they're relaxing some of those Medicare requirements, and also Medicaid as well. So you'll see that mirrored again also in the states, and trying to meet a need. Perhaps there's a shortage in the state for a certain type of specialists, and allowing out-of-state providers to more easily provide those services to Medicaid patients. Stark laws, I did mention a little bit about that with the copays, but there are other Stark laws where, again, they were relaxing them a little bit, because with telehealth, when you have a telehealth arrangement, especially when you're dealing with distance site providers, there are a lot of exceptions to make sure you don't violate a Stark law, but sometimes it's a little bit it looks a little bit too close sometimes. So they're saying like, we're going to relax some of those, understanding that you may be trying to like ramp up very quickly. And then supervision and practice at the top of licensure. There are other regulations or rules around that CMS had, Medicare had about supervising, such as perhaps there may have to be some sort of in-person type of supervision, and saying like you're allowing it to be done over video with a supervising provider just during this emergency period. So relaxing some of those as well. And those are just links to some of the sources where this information is from. Next slide, please. So one thing that I did want to focus a little bit of more time on was the ability of FQHCs and RHCs to act as a distance site provider in the Medicare program. So in Medicare, they were not pre-COVID-19 allowed to act as a distance site provider. Medicaid, it was a little bit different. So again, like I said, Medicaid programs have actually quite a bit of flexibility in how they do telehealth. So some states will allow FQHCs to be distance site providers, others didn't. And part of the reason was for whatever reason, but one reason was because Medicare had not allowed it. Some states, I think, were mirroring the Medicare policies of not allowing it. But now in this emergency situation, Congress had said like, yes, FQHCs and RHCs can act as a distance site provider. So that could impact the Medicaid program and your programs as well, having them be available as providers to provide services. Next slide, please. So virtual communication services. So these are, there's a grouping of services called virtual communication services or technology-based services that Medicare does not call telehealth. And that means that they use telehealth technologies and they can provide services. They have specific definitions and requirements on their own, but because they're not called telehealth or they're not labeled telehealth, all of those previous restrictions around how Medicare deals with telehealth delivered services don't apply to these. So such things pre-COVID-19, such as, oh, you need to be in a certain geographical area or you have to be the certain type of provider, they don't apply to these virtual communication services, even though they're using telehealth technologies. It's because they're just not labeled telehealth. So this is also where you will see in the Medicare program, phone being allowed. So right now, underneath Medicare, if you're talking about telehealth, the telephone is not allowed. It's the separate set of services where you can use audio only means of communication of delivering the services, the phone. That's what they're talking about. It's these virtual communication services. And FQHCs and RHCs are allowed to provide some of them. And these are like the virtual check-in services. So that's exactly what it sounds like. It's a quick check-in. It's like 5 or 10 minutes. There's other parameters around it, but it's not considered like, you know, a very long consultation or an actual office visit. It's just a quick check-in. And then something called online digital evaluation management services. It's usually like an online portal that they can use. These are services FQHCs can provide and get reimbursed for in this cluster of other non-telehealth designated services. Next slide, please. And these are more groupings of those exact types of services. And why I wanted to point this out specifically is to let you know that there is a grouping of other services that CMS and Medicare does not view as telehealth, but it uses telehealth technologies. And B, quite a few states are actually using some of these services, but they're not calling them telehealth. So they are, Medicaid programs are reimbursing for some of these services, but you're not going to pick them up if you're searching for telehealth. They will just actually, you know, call them like remote chronic care management or virtual check-in, or they call this G2010 codes. So just keep that in mind, in that it's not labeled telehealth, and it may not be labeled telehealth, most likely not labeled telehealth by your Medicaid programs, but they're available there as like another means or other cluster of services that can be provided, can be used, and get reimbursed for. Next slide, please. So state Medicaid programs, very different policies. You'll hear from Ohio and you'll see how very different it is. But I'm going to go over what some of the more common changes are we're seeing in COVID-19. Next slide, please. Oh, before I get to that though, that's right, DEA. So I wanted to put this in here. So this is not related to Medicare, but is federal policy, something else that is going on, and that is what the DEA is doing. So the DEA is, they have control when you're prescribing, the feds have control over prescription of controlled substances, and that comes underneath the DEA's purview. So where controlled substances are concerned, it's federal law, and there's a narrow band of exceptions where you can use telehealth to prescribe a controlled substance without having an in-person exam take place. One of those exceptions when a public health emergency has been declared. Public health emergency has been declared, so that exception kicks in, and basically that exception is, if it's done for a legitimate medical purpose, if it's done over live video, and if you're acting in accordance with federal and state law. So it's an added flexibility given to providers in providing controlled substances. And I know a lot of people are thinking like, it's been more prominent in a lot of people's mind in treatment of opioid use disorder, but there's also a lot of mental health conditions where they may need to prescribe a controlled substance as well. And I thought that would have, implication again for the population this particular folks are particularly interested in. One other thing, this is specifically for OUD, opioid use disorder. They are allowing prescription of buprenorphine over the phone if certain conditions are met. So I just put that out there. I don't know how much application that will have for the population you guys serve, but I'm just putting that out there as one other policy change that was made. Next slide, please. So what's going on the states? So pre-COVID-19, you basically had all the Medicaid programs for all states in DC doing some type of live video reimbursement. It varied. Store forward and remote patient monitoring, not as popular, and they had a lot of conditions around, like store forward. It was like maybe for dermatology, a specific type of specialty. Remote patient monitoring may have been for like chronic conditions, which is important to know because not a lot of states had allowed the home to be an eligible originating site. If they did, it usually was for specific types of conditions. It wasn't a blanket, you're allowed to just do whatever services in the home. So it was usually for something specific. Next slide, please. You also had most states having some type of private payer laws, and these are laws that are on health plans telling them what they have to do for telehealth, and they can range from all the way from health plans, you are allowed to cover telehealth, to health plans, you shall cover telehealth the same way you did if services delivered in person, and by the way, you will pay the same amount, and everybody else kind of falling in between. So that was also on what's out there on the landscape as well. Next slide, please. So during the COVID-19 world, what are some of the common changes that we're seeing on the state level? What are they doing? Like Medicare, they're mirroring that, allowing the home to be an eligible site. Very logical. A lot of us are, sheltering at home, so that's like logical in order to like provide those services. They're also allowing telephone to be used to provide services. And again, that has come up because not everybody may have access to a computer or a smartphone. There's a recognition that this may be the only way to reach some people. Keep in mind though, that you may need to dig a little bit deeper. Some of these Medicaid policies, when they say we're allowing phone, they may just be talking about that virtual check-in code that I talked about earlier. So we've run into providers who are saying like, hey, I did telehealth over phone, but I only got paid $10. Well, it's probably because they were billing for the G codes, which are these quick check-ins, which aren't meant to be paid a lot. They're supposed to be like $10 or $15. So that's probably what they were doing. And they were not billing for like a consultation visit. And that may be because Medicaid policies may say, we're allowing phone, but what they mean is we're allowing these virtual check-ins. Requiring health plans, managed health plans to cover telehealth services, depending on what their state laws are. Again, the orders are ranging from like, we're encouraging you health plans to cover more telehealth services to states saying like, you're covering telehealth services. So again, that's sort of like one of the more common executive orders we've been seeing. Next slide, please. Less common changes that we're seeing is expanding modalities beyond the phone, like not seeing a lot of states saying like we're going to do more store and forward, that type of thing. They may be enclosing it in like just their definition of telehealth, saying like we're just going to expand telehealth, and that may be already worked into the definition that they meant expanding store and forward. But it hasn't been as clear as a direct order saying we're allowing phone coverage. Expanding the list of eligible providers to include other professionals such as allied health professionals and FQHCs and RHCs. That's been kind of like less of a more common policy change that we're seeing on the state level. And then waiving consent requirements. Actually, most states have some type of telehealth consent requirement. either in their Medicaid program policies or actually on statute in law or in regulations. We're seeing not necessarily waiving it wholeheartedly, but maybe like relaxing some of the consent requirements, saying that if it had to be written before, they could say you get oral consent. Next slide, please. So these are just some links to some of our resources as well. What I did not put on here is we actually did, before COVID-19 hit, did do a study of like what states were reimbursing which of those telecommunication-based codes in their Medicaid programs, and that is actually available on our website that you can download. We used the January 2020 information, so you can see actually which states are billing or reimbursing for those virtual communications or communication-based technology codes that don't count as telehealth, but as like an other, but they use telehealth technologies. And next slide, I think that's it. And I'll just turn it back over to Alex, I think.
Great. Thank you so much, May, for that wonderful overview of everything that has changed so quickly. And we really appreciate you kind of grounding the conversation in terms of where some of those trends are and what the opportunities are. So I'm now going to introduce our Ohio speakers, who we're thrilled to have joining us to share a little bit more about how this has played out in Ohio. We have Leslie Scott Charlton, who serves as the Medicaid School Program Administrator at the Ohio Department of Medicaid. Leslie has over 20 years of extensive experience in social services, eligibility determinations, program administration, and policy development. And she is also an active participant in numerous federal and statewide collaborative efforts alongside partners from other governmental agencies, local health departments, managed care plans, and family stakeholder groups. We are thrilled to have her as a member of the Healthy Students Promising Futures Learning Collaborative. And then Bernadette Laughlin is the Related Services Education Program Specialist in the Office for Exceptional Children at the Ohio Department of Education. Bernadette has been with the department for 9 years, previously serving as the speech language audiology consultant, due process coordinator, and a complaint investigator. Before joining the Department of Education, Bernadette was a school speech language pathologist for many years, a special education department facilitator, and an Ohio and federal legislative liaison for several professional organizations. So we are thrilled to have Leslie and Bernadette sharing a little bit more about how this has played out in Ohio. So Leslie and Bernadette, I will now hand it over to you.
Thank you, Alex, for that awesome introduction. And thank you guys for joining us today. I am really excited to share with you guys some information about Ohio's move towards telehealth and our school-based program. Next slide, please. Before I get started, I thought it'd be a good idea just to give you guys some quick information about Ohio's Medicaid school program. Our program in Ohio is set up to allow our Ohio Department of Medicaid to reimburse schools for certain health-related services that meet our medical necessity criteria when those services are provided to Medicaid-eligible children between the ages of 3 and 21, and when those services are identified in the student's Individualized Education Plan, or IEP, and when it's done in accordance with the Individuals with Disabilities in Education Act, or IDEA. IDEA, or IDEA, mandates that public schools provide special education services to students with disabilities to ensure that those students actually have access to a free and appropriate education alongside their peers who may not particularly have special education needs. Next slide, please. Within the next 3 slides and approximately 4 minutes or so, I hope to give you a high-level overview of Ohio's telehealth movement and how we involved our Medicaid school program. Allow me, though, if you will, to give you the speedy version, but actually in the reverse timeline from present day backwards. So here we go. At the onset of the COVID-19 pandemic, Ohio's Governor Mike DeWine and his executive leadership team expeditiously moved to expand our telehealth and services and issue guidance related to the delivery of the expansion of those telehealth services. The expanded telehealth services were across the board and it was to benefit all and not just the individuals that we serve through our Medicaid school program. The expanded rule served several purposes. One, it included a wide array of medical, clinical, and behavioral health providers and counselors. Two, it eased technology restrictions on patient-physician interactions to deliver the telehealth services. And three, it reduced prior authorization requirements for many medical and behavioral health services. Now, there are three pieces of information that I'd like to share with you, which I hope will provide you with some additional context behind our transition. Section 119.03, capital letter G, of our Ohio Revised Code actually authorizes the governor to suspend the normal rulemaking procedures when an emergency exists that necessitates the immediate adoption, amendment, or rescission of any of our rules. And for those rules, we could allow them to be valid for up to 120 days. On March 9, 2020, Governor Mike DeWine declared a state of emergency, and he issued an executive order noting the need to relax administrative rules to allow the rendering of telehealth services in an effort to minimize the impact of the virus and support the need to quarantine and adhere to social distancing standards. On March 19, 2020, the governor authorized emergency telehealth provisions related to telehealth services during our state of emergency. So with the placement of the governor's executive order and the adoption and amendment of emergency rules, as well as the swift turnaround on the creation of supporting documents such as a telehealth FAQ and a telehealth infograph. And moderator, if you could click on those last three links for me as I continue. The Ohio Department of Medicaid was postured and positioned to move quickly to support the delivery of telehealth for school-based services. And you don't have to stay, just click and continue to move. Thank you. And moving on to the next slide, please. So here in Ohio, we have some schools who continue to serve students during the COVID-19 crisis. And those schools were able to do so remotely, or should I say virtually. With the decision to continue to meet students' educational needs, schools were also required to meet the students' IEP needs. As such, the provision of telehealth services were in place, and it allowed the schools to utilize technology to meet the school-based health needs of those students with IEPs. Some of the benefits that the utilization of telehealth brought to the table included less exposure to illnesses, including COVID-19, no transportation needed, it was time-saving, secure and private, and it allowed for both synchronous and asynchronous communications. Next slide, please. So in conclusion, as I promised you 4 minutes or less, I'd like to share with you that prior to the onset of COVID-19, and specific to our Medicaid school program, Ohio was already paving the way for telehealth services to meet the needs of students. Before the emergency telehealth rule, we were acknowledging speech language pathology, or SLP, and was working to update our reimbursement system. We call it MITS, but some of you guys may know it as the Medicaid Information Technology System. And we were working to allow claim reimbursements to our schools when they submit speech language pathology claims. Fortunately, the executive order and the emergency telehealth rule helped to accelerate this process. Now, during the span of the emergency telehealth rule, the filing actually allowed for the reimbursement of most skilled therapy services and not just speech language pathology. Thus, we were allowing the services to be authorized in our Medicaid school program as well. And that included, as Mai said, OT and PT, some behavioral health services and nursing services as well. And it additionally relaxed the previous requirement for the need of an initial face-to-face visit prior to the telehealth visit. Now, with all of that being said, it is important to also share with you that we do have plans for the Medicaid school program after the expiration of the emergency telehealth rule. Prior to the emergency telehealth rule, we were doing some research and feasibility studies. The emergency rule, because it does have an expiration date, as such, so does the added services that were amended for the purpose of the emergency filing. When the rule expires, the telehealth rules will revert back to its previous non-emergency version, which was SLP, or speech language pathology only. Before the emergency rules were filed, we were considering adding the other added services to our broader telehealth rule, and that is actually still under consideration for the Medicaid school program, for the purpose of the Medicaid school program. If approved, those changes will be incorporated and it will allow us to provide the additional services in our Medicaid school program as well. So now I'm going to turn it over to my colleagues at the Ohio Department of Education as they talk about some of our collaborative efforts. Bernadette.
Hello, everyone, and thank you for this opportunity to be here. Next slide, please. And can move on to the next slide, too. With this emergency, national emergency that we are all under right now, a top priority for us at the Department of Education was providing our special education and the related services, such as speech language therapy, OT, audiology services, school nurse services, and school counselor services as well. We had 9 years ago, when I first came to the department, had looked at telehealth as a way to reach some of our rural districts. We have a lot of rural districts in Ohio, and many of those districts have difficulty with staffing, having speech language pathologists, school psychologists. And we were fortunate enough to have research at Kent State University from Sue Grove and Johnson that showed that telehealth was as effective as the in-person kind of therapy. However, we really could not get some of our schools very interested in using this mode of service delivery. Well, along came COVID-19, the national emergency, our state emergency, and then on March 23rd, our governor declared a stay home or shelter in place order. And all at once, as Leslie has already mentioned, we were responsible for providing these services. However, now how would we do that? Well, telehealth suddenly became very interested to everyone. And when we were able to get the Medicaid reimbursement for these services, the school districts were just delighted and very interested. So we were plunged into it kind of all at once. Next slide, please. In addition to our students with disabilities, the new Medicaid reimbursement rule was going to cover the mental health and well-being of our students, of all of Ohio students, not just those students who are identified as a student with a disability under IDEA. And this was something that we were very excited to see happen because, you know, during this national emergency, some of our students who have behavioral health needs, mental health needs, and who were seeing counselors and school social workers. So this was a very, very welcome addition for us. Next slide, please. So as Leslie has already pointed out, the emergency rule expands and enhances the telehealth option. And this emergency rule was effective March 9th. We are very excited. As I said, many of our schools are just learning with this new option, but as Leslie indicated, I see it as going forward. I think even after the national emergency, I think if we can say that maybe something good has come out of this national emergency, maybe it has been the fact that we were sort of forced to use telehealth and to look at all the possibilities that it can provide for us. So I'm looking forward to this and very excited to be working with the Department of Medicaid on this. Thank you.
Great. Thank you so much, Bernadette and Leslie, for that fantastic overview. Next slide, please. It's really exciting to hear more about what's happening in Ohio around this and just the speed at which the state has really moved forward on leveraging these flexibilities to support delivery of school health services. And also fantastic to hear about the collaboration between Medicaid and education. So thank you for sharing that. So we're going to move into our question and answer session here. Please feel free to send in your questions through the questions box. While you're thinking of those questions and typing them in, send them in. We'll ask some of the presenters. I just wanted to share some action steps for you all to think about, as you consider moving this work forward within your state, within your community. As we heard from all our presenters, I think, a critical step is really mapping the policy landscape within your state and understanding, what was that landscape prior to COVID-19 and what has changed in response, and where there are new flexibilities to be supporting the delivery of school health services. Certainly really documenting what works for providers and families. Bernadette did a fantastic job of, teeing up that we hope, the lessons learned and work that is happening right now won't go away. We know that telehealth is an incredible way to be delivering these services, and there's going to be a lot of lessons learned from this work. So really documenting those lessons learned, where there are issues, with an eye towards sustainable change with these policies. And then certainly same, tracking encounters, tracking the data as far as what this looks like at the local level to, again, make that case for the impact and using that data to identify gaps, to better understand who is receiving these services, and then more importantly, who isn't. And then again, just to, underscore that while a lot of these, policies do sunset and are linked to specifically to COVID, we really do see this as, opening an important policy window to make the case for changes that are needed to support the delivery of school telehealth services in the long term. So next slide, please. We will now open it up for question and answers. I also want to share that you'll likely hear an additional voice. We have Mark Smith, who's an administrator with the Ohio Department of Education and serves as the agency's Medicaid lead. And so he will likely be weighing in on some of the questions as well and sharing more of the Ohio perspective. So just a question for Ohio is wondering if you could share a little bit more about how you have supported the rollout of these changes at the district level. Is there any guidance that the state has put out? Are you fielding questions? Just kind of a little bit more about maybe how these changes were communicated so that districts could leverage the opportunity.
This is Mark with Ohio Department of Education. One thing that I want to share with all of you is that both the Ohio Department of Medicaid and the Ohio Department of Education have been working diligently to put out frequently asked questions based on the very question that, how do we do this? What are the circumstances that, are and are not allowable to do things? We're all doing this on the fly. And the one thing that I want to say to all of you is, if not now, when? Because there is a necessity that we have before us to be creative, to be innovative, and to think outside of the box. And while we at the Department of Education and my colleagues at the Department of Medicaid want to give people, some level of structure on how districts can do this, we don't want to be overly prescriptive and sort of stifle the innovation that I'm sure is out there in Ohio and all the other states. The Department of Medicaid has their FAQ finalized. We're still looking at the final version of the Department of Education's FAQ, and we look at these to be dynamic documents. And so we've reached out via our billing agents to share information, as we know that there are questions that are out there, but we also wanted to give something a little bit more permanence in terms of an FAQ. And then lastly, to tell everyone, we want you to do what's right for kids. And if we have to sort of bend things a little bit to help districts provide the needed services to kids, we're willing to reach out to folks in a way that we probably don't have, the visibility of being as flexible outside of this pandemic.
Great. Thank you so much, Mark. And Leslie, Bernadette, anything else to add on that point?
Just in sharing or following up what Mark said, we also, specific to our school-based Medicaid program, we also meet with our stakeholders monthly, including our Department of Education. We have these the third week, usually the third Thursday of every month, and it includes even our school districts, our school billers, parent advocates, providers, associations, you name it, we try to have them at the table. And that kind of helps us to prepare to propel ourselves forward. And it actually was extremely beneficial in this whole COVID transition. So the collaborative effort is really part of the equation that helped us move some of our school-based conversations forward.
Great. Thank you so much, both, for weighing in on that. So there's another very specific question for Ohio, and we're getting a few questions along these lines of if you could say a little bit more around how, what type of documentation you're using, specifically kind of how were you tracking the uptake of telehealth, of speech language pathology services prior to COVID, and then folks wanting to know kind of what type of documentation and tracking you have in place moving forward.
Thank you. Great question. I'm sorry, I was trying to unmute. We so prior to the COVID-19, as I stated earlier, we were positioning ourselves for the speech language pathology. And because our system changes, our reimbursement system changes, we're not yet in a position to allow us to provide reimbursement. Now that COVID has happened, our system, by way of emergency, had to get prepared. So my Medicaid school program was trumped by some of the more emergent things, which was great. So as a result, we'll be able to track it from beginning. We'll be able to not only track speech language pathology, but we'll be able to track the other therapy types during this 120-day transition, and if it goes on longer, but we'll be able to track it during that time frame. And then hopefully we'll have our rules in place and our system in place to allow it after COVID-19, and then we'll be able to track it that way as well. One of the tracking mechanisms that we're using so far is we're looking at that GT modifier, how many of our claims actually have the GT modifier attached, and as well, how many of those claims are telehealth specific. So hopefully that helps to answer the question. If not, feel free to keep the questions coming.
Great, thank you, Leslie. So another question, I don't know, May, maybe if you have thoughts on this, or our team from Ohio, just specifically regarding parity, and if there's efforts doing to keep prices down and fair for customers, you know, if you're seeing any increases in prices as a result of increased delivery of telehealth services. Just wondering if there's any insights to share kind of around overall costs. So I don't know, May, if you have thoughts on that, or if Ohio, if that's been something that you all have given thought to.
I'm going to assume they're asking about cost on buying the equipment. If that's,
I think it's more kind of copay visit costs. So less setup and more visit costs, copays, that type of thing.
Yeah, you know, actually, it's been interesting during this emergency period. What you've been seeing, as I mentioned in my presentation, at least they're allowing that to be relaxed in providers and collecting copays, like the Medicare program was allowing that to be relaxed somewhat. I've seen a lot of announcement from health insurers themselves that where telehealth is concerned, where they're providing telehealth services, some of them are actually waiving the copay for that. So it's going to vary between payer to payers and what they do for telehealth services. Now, a lot of the policies, though, if you're talking about it's a direct COVID testing or treatment directly related to COVID, like Medicare has said, like you're not supposed to charge copay for that, and you're seeing that with like some of the other states saying that as well, where it's directly related to COVID or COVID testing for COVID, then you're not supposed to have a copay. But where in general for telehealth delivery of services, you're actually seeing a lot of health plans either saying, well, we'll have like a period of like 2 or 3 months where you don't have to pay a copay, or they're like reducing that, or they're waiving that. But that's going to vary from plan to plan.
Great. Thank you, May. That is incredibly helpful answer. We really appreciate that. So then we're getting quite a few questions about school nursing services. So wondering, Leslie, Mark, Bernadette, if you might be able to comment on this, wanting to know a little bit more about what reimbursable services school nurses are providing via telehealth, if you could just give some examples. And then I think in general, just if you have any guidance, specifically, we have a lot of school nurses that are on the webinar today, just any kind of words of advice as school nurses, are thinking about really setting up these working to set up these telemedicine programs within their schools.
And this is Leslie. I would like to share that I'm not well versed just simply because of the nature of it being so new. But what I am glad to share is that our guidance documents are available on our website. And if you click on, after the webinar, if you guys click on those links, it will take you to documents that will show you what our services are, who our providers are. And we also have a list. It's actually linked as an appendix that has all of our emergency telehealth billing codes and the rates associated with it. So I provided that information in the hopes that it will be extremely beneficial to some of our peer states who are moving forward in these types of initiatives as well.
That's fantastic, Leslie. Thank you. And we will, again, make sure we share the slides, and we'll also specifically share those links in the follow-up email. I don't know, Mark or Bernadette, do you have any other kind of words of advice for school nurses, or really any practitioners that are working to set these programs up within their schools?
The only thing I would add, and Mark mentioned this already, is that the Department of Education is also working to get an informational document out on telehealth. So please just watch our website. That should be posted, I'm hoping, in a few days. And also, my colleague, Anna Miller, who is at the Department of Education and works with healthcare, who could not be with us today for this, but she is another resource at the Ohio Department of Education for telehealth. And thank you.
And to follow up with what Bernadette just said, truly it has been a collective and collaborative process. We have folks at our department who is way smarter, way faster, and way more well-versed in telehealth and policy changes related to it. And so we've just all come together. When you hear the term, we're all in this together in Ohio, we really are. It has been, the process has been a transition indeed, but it was extremely effective from my purview.
Great, thank you. And I'm just going to squeeze in one more question for May before we wrap up. Just May, wanting to know if you have any thoughts regarding kind of how to make the case for having some of these policy changes be more long-term, if you think that there is an opportunity there, and then if you have any recommendations to states and localities about how they can kind of make the case for the need for these services moving forward.
Yeah, I think COVID really helped. I hate to say this, the pandemic really helped in pushing the discussion forward on telehealth, in that it showed that we really do need these services out here, that there were populations that could not access some of these services. Now, the argument to like keep some of these changes around, because a lot of them, practically all of them, are temporary changes. I know a lot of people are doing a lot right now But one of the things that always works even before COVID is making sure that you had data there. And I was happy to hear like of all the tracking that, you know, Ohio will be doing, because that's always been one of the areas that telehealth has kind of been lacking, is like the data of like, you know, how much telehealth has been provided and what's been the impact of that. So where providers, where programs could collect data and like not only the utilization, but also, you know, if you could show it was effective, that would be very important. And what's also important is also getting information back from the people that you provide the services to. In this case, to not only students, but also to like their parents or their caregivers, their families, just what was their experience with telehealth and what their reaction has been, and their experiences with it. What was lacking pre-COVID-19, I think, was like a lot of consumer exposure to telehealth. So I don't think policymakers had heard enough from the consumer voice of saying like, we want this will benefit us in the long run if it be made available to us.
Great. Thank you so much for that. That is very helpful words of advice to consider as we all move this work forward. So I just want to thank our speakers once more. Thank you to May, Leslie, Bernadette, and Mark. We so appreciate you sharing your expertise. And thank you to everybody for taking the time to join us today. On the next slide is my contact information. Again, we will be sure to share in the follow-up email links to the slides, the recording, as well as many of the resources that were mentioned on today's webinar. So thank you once again, everybody. We hope you all stay safe and healthy, and appreciate you taking the time to join today's webinar. Bye.
Thank you.
Thank you.
Thank you.